Hello everyone, happy evening, a very good evening. Am I audible and visible, everyone? Happy evening, everyone. I hope and I believe all of you are doing well. A quick nod, am I audible and visible, everyone? Okay, that's great, guys. So this is the Fast 5 test for those who are new here. What is Fast 5 is these are long stem clinical questions. Now in the recent exams, whether it is FMGE, NEET PG, INICET, you are seeing that it is clinical integrated questions that are appearing in your exam. So, you should keep practicing such questions. Basically, these are like, USMLE type of questions. So we practiced just 5 MCQs. This was the 6th test that we have. There are previous 5 tests that are available in the Medsynapse app by Dr. Nikita, which is free for all. Let me quickly tell you that how can you access those tests on the app is, like once you go to the Medsynapse app by Dr. Nikita, on the home page, you would see this free content wala tile which is there. In the free content, once you go there, you have this final punch short LMR, PYT, previous year topics PDF available for free. There's a free all subjects TND course also available, and you have this Fast 5 clinical MCQ test discussion. Once you go there, you will see this test 1, test 2, test 3, test 4, test 5 and test 6, which is going to be uploaded. With every video, you have this attempt test option, so you can attempt the test and then you can watch the video there and there. And you have the PDF also attached to every video. Once you click on view PDF, you will have the PDF without annotation and PDF with annotation, that is blank and annotated both. For this test as well, I'll be uploading both the blank and the annotated PDFs in the app in this location, which is the free content and the Fast 5 clinical MCQ discussion. Okay. Yes, so let's quickly discuss the Fast 5 questions for today, guys. First question that you see here is, so the graph shows changes in serum estradiol concentration. Remember, whenever there is like 3-liner, 4-liner question as well, it's always better you start reading from the last line because it gives you the crux of the question. So, which of the following ovarian cells is primarily responsible for aromatization of androstenedione to estradiol at the time indicated by the arrow? So even if this graph is not there, this is just a one-liner, the last line question which is there, you know that aromatization of the androgens to estrogen takes place in what cell in the ovary? That is the granulosa cells. Remember, aromatization takes place in the granulosa cell. That is why, like if you try to integrate it clinically, the ovarian tumor that you read, that is granulosa cell tumor. Can you quickly tell me what is the clinical feature that it can present with? This is an ovarian tumor, granulosa cell tumor. Remember, in granulosa cells, aromatization takes place. So there is going to be increased estrogen, and that increased estrogen can either lead to precocious puberty or it can lead to abnormal postmenopausal bleeding as well, right? Because of the increased estrogen, right? Everybody remembers that. So granulosa cell is where the aromatization takes place of androgens to the estrogen. This is where you see that just before ovulation, right, the LH surge, the rise in estrogen is what leads to LH surge, right? Around mid-cycle, you will see the ovulation, the LH surge, which is going to be there. Is this clear with everyone? Definitely, it is not going to be luteal cell because luteal cell, corpus luteum, comes after ovulation. The arrow is showing before ovulation, so definitely it is not luteal cell. Is this clear with everyone? Right? And another quick question here related to aromatization. Can you tell me drugs which are aromatase inhibitors? What are the drugs which are aromatase inhibitors? Remember, aromatase inhibitors will prevent the formation of this estrogen. So you use it in breast cancers, right? So what are the drugs which are aromatase inhibitors? Anyone? Which drugs are aromatase inhibitors? Yes. Anyone? Which drugs are aromatase inhibitors? You use them in breast cancer. When you cannot use tamoxifen, then you use aromatase inhibitors like in postmenopausal females. Very good, Rahul. Correct. Letrozole and nestrozole. Remember, Madhav, finasteride, teride wale drugs, those are your reductase. Ride is reductase. Look at the spelling of the drug. So that is 5-alpha reductase inhibitor, preventing the conversion of testosterone to 5-dihydrotestosterone. The trozole drugs basically are going to be your aromatase inhibitors. Anastrozole, letrozole. Okay, that is letrozole. TR testosterone to 0 estrogen. TRZE. That is what you should focus on. Testosterone, 0 estrogen. So androgens are not getting converted to estrogen. So it is letrozole and nestrozole. Okay, clear with everyone? Now, since we are at granulosa cell, tell me the CD marker for granulosa cell. Remember granulosa cell tumor, what is a mnemonic in short we have seen? It is granny, 99-year-old granny who's always excited, can never be inhibited. So inhibin is the marker for this, inhibin B, right? And she calls her X, that is called Exner bodies. She calls her X over a cup of coffee, coffee bean nuclei, and the X gets roses for the granny. That is pseudo rosette appearance is what you see here in granulosa cell tumor with the pink material in between, and the nucleus is coffee bean nucleus. Okay, remember 99-year-old granny cannot be inhibited, calls her X for a cup of coffee, and the X gets roses for the granny. Okay, so that is CD99. I hope all of you remember this quick story mnemonic for granulosa cell tumor. Okay, so remember the aromatization takes place in the granulosa cells. Okay, is this clear with everyone? Right? And now since we were at the estrogen ke forms, also let's quickly discuss when do you see, when do you have estradiol and when do you have estriol? Estradiol, remember di is do log, right? Like the husband and the wife, the girlfriend and the boyfriend, just two people, that is the reproductive age group. Estriol is when the baby also comes in, that is during the pregnancy, right? And when it is a lone female, right? A widow, postmenopausal female is single, alone, one. So that is when you get estrone, right? That is single. Now, logically thinking, this is one of the INICET PYQ, that which is the most potent form. The reproductive wala is the most potent form, that is estradiol is the most potent form of estrogen. Which one do you test for in the triple marker, quadruple marker? So that is in pregnancy. So triple marker, quadruple marker, you have estriol, not estradiol, and that too unconjugated estriol. Okay, that is unconjugated estriol, UE3, unconjugated estriol. Is this clear with everyone? Right? So menopause wali single female 1, reproductive age 2 diol, and pregnancy triol. So in triple quadruple marker you have unconjugated estriol. Okay, and the most potent is going to be estradiol. So these were the quick points related to this topic. Going on to the next question. Seems like a difficult, complicated question, but actually it's very easy. 14-year-old girl, there is history of a rash, and there is serum tryptophan concentration is decreased. Urine mein there is increased amino acids. So production of which vitamin is likely impaired? So very important clue given here that tryptophan is decreased here. So basically, which vitamin is derived from tryptophan? What is the quick trick? Remember, tryptophan is tryptophan tri, that is vitamin B3. Niacin is what is derived from tryptophan. So it is going to be niacin deficiency. What is the disorder here? Where there is excretion of these neutral amino acids in the urine. This is Hartnup disease. The intestinal renal absorption is affected. So tryptophan is going out. Remember, 60 milligram of tryptophan forms 1 milligram of niacin. Is this clear with everyone? So tryptophan, if not there, the niacin will not be there. Deficiency of niacin. There's going to be pellagra-like features, the 4Ds, diarrhea, dermatitis, dementia, and death. So dermatitis, remember the rash, Casal's necklace is what you see in pellagra. Okay, is this clear with everyone? Correct. Which other disorder basically can have pellagra-like features? Because all the tryptophan is getting diverted to form serotonin. So remember, one is Hartnup, second is carcinoid, right? So remember from biochemistry, short again, trypto forms serotonin, and it forms B3. If all the tryptophan is going to form serotonin, the B3 levels will decrease. So in carcinoid also, you will have pellagra-like features. Okay. Carcinoid, remember what is the tumor marker? The urinary excretion of 5-HIAA, right? Which is derived from serotonin. 5-HIAA is what is increased in carcinoid. Very, very frequently asked question in the exam. Very, very frequently asked question. Okay. So that was about the second question. Going to the next one. Okay, this is also based on the short concept that we have studied in physiology there, renal physiology. So, treatment with an angiotensin converting enzyme, that is ACE inhibitor, will have which of the following effects on the renal function, right? So, even if I read this, the question is, what will ACE inhibitors do in the kidney? So, what is the trick that we have learned here in the renal physiology, guys? Short. Yes. Now understand that the trick, the mnemonic that we have seen is PDA and ACE. Prostaglandins dilate the afferent. PDA, prostaglandins dilate afferent. ACE, angiotensin 2 constricts the efferent. So if you are giving this ACE inhibitor, the angiotensin will not be able to act. So that is why the constriction of efferent will not take place. So therefore, there will be dilatation of efferent arteriole. Right? Remember, there will be dilatation of efferent arteriole. So if you remember from short renal physiology, we have seen this afferent, then the GFR, and then the efferent. Afferent is the incoming wala road, efferent is the outgoing road, and GFR is the bypass. So if you increase the afferent, the incoming traffic, the bypass traffic will increase. If you make this outgoing road narrow, all the traffic will be diverted to the bypass, that is GFR, right? So what causes increase in GFR? Please try to understand this. Increase in GFR is dilatation of afferent and constriction of efferent. The PDA, dilatation of afferent, and the ACE, constriction of efferent. This is caused by prostaglandins and this is caused by angiotensin. Okay. So when you give ACE inhibitors, it leads to dilatation of efferent and the GFR will decrease, right? So remember, the effect will be on the efferent arteriole dilatation, leading to decreased GFR. Is this clear with everyone? Dilatation of afferent, that is incoming, will not decrease the renal blood flow. It will increase the renal blood flow, and this is done by prostaglandins. So that is why NSAIDs, they can cause the decrease in the renal GFR by affecting this prostaglandin mediated dilatation of afferent. Concentrating ability, secondary to change in permeability of collecting duct. What hormone acts on the collecting duct, changing the water permeability? This is the action of ADH, right? ADH acts on collecting duct. Please remember that. It is not the ACE inhibitors. Okay. Clear with everyone? Right. So remember this very important mnemonic here, which is basically your PDA and ACE. Okay. What is the trick here? The trick here is PDA and ACE. Prostaglandins dilate afferent, angiotensin 2 constrict efferent. So both of them increase the GFR. Okay. So if you look at the question here, a 25-year-old woman, high blood pressure, no medications, no family history, and there is bilateral abdominal bruit. So remember that bruit anywhere is indicating there's narrowing in the vessel. So basically there is some stenosis which is present. So this is a patient who has renal artery stenosis, maybe most likely due to fibromuscular dysplasia, which is a cause of renal artery stenosis in young females. And that renal artery stenosis leads to secondary hypertension, the renovascular hypertension. Now remember that a patient who has renal artery stenosis, the angiotensin constricting the efferent is what maintains the GFR. So therefore, if you give ACE inhibitors in those patients, the GFR can fall significantly, and that is why in renal artery stenosis, the ACE inhibitors are contraindicated. Okay, the ACE inhibitors are contraindicated in renal artery stenosis. Is this clear with everyone? Yes, clear with everyone? Right? So that is about this question. Going on to the next question here. 20-year-old woman slipping, and there is anatomical snuff box tenderness. So fracture of which bone? Very, very important, and it's like a PYQ that has been asked in previous exam. Anatomical snuff box is present here near the thumb. So on the radial side, you have what bone? That is scaphoid. Remember the carpal bones ka mnemonic? She looks too pretty, try to catch her. So scaphoid, which is on the thumb side, the radial side, that will produce anatomical snuff box tenderness. Okay, scaphoid fracture will produce anatomical snuff box tenderness. What X-ray view do you take to look for scaphoid fracture? It is oblique view, which is important. What is the risk that you are worried about with scaphoid fracture? AVN, avascular necrosis. Of which fragment? Proximal fragment or distal fragment? Which fragment of scaphoid is at a risk of developing AVN? Proximal or distal? Yes. Is it proximal or is it distal? So understand the fact that if this is the scaphoid, the distal end, the proximal end, the blood flow that comes, okay, the blood flow that comes in the scaphoid, it comes from the distal to the proximal. So when there is a fracture here, it is the proximal area where the blood supply is affected. So this is going to be the AVN of the proximal fragment, which is the proximal fragment is at a risk. Okay, because it is the blood flow which comes in the reverse direction. Is this clear with everyone? Yes, not the distal. Rajat, remember it is proximal, not the distal. Okay, so proximal fragment is at a risk, and that is AVN. It is the lunate bone dislocation or lunate bone fracture which can lead to median nerve compression. Okay, remember median nerve compression is because of the lunate fracture or lunate dislocation. Anatomical snuff box tenderness is scaphoid fracture. A quick question here. What is the quick question here? Tell me the muscles forming the borders of the anatomical snuff box. Anatomical snuff box, what is the lateral border and what is the medial border, guys? Anatomy, very, very important. Remember, two longest muscles cannot go together. So lateral में पहले आता है abductor pollicis longus, medial में आता है extensor pollicis longus, और इसके साथ आता है दूसरा brevis, which is extensor pollicis brevis. So remember, one is longus, one is brevis. APL and EPB form the lateral border. Medial is the EPL, that is the extensor pollicis longus. Absolutely right. Okay. See, when do you get the Terry-Thomas sign? Terry-Thomas sign is when you have this scaphoid and lunate and the ligament connecting the two. The scapholunate ligament is broken. So the gap between the scaphoid and the lunate increases, like the gap in the teeth of Terry-Thomas. So that is what gives the Terry-Thomas sign. The scapholunate dissociation, that ligament breaking, that gives the Terry-Thomas sign. Okay? Clear with everyone? going on to the last question of the fast five for today. So the question is, which of the following disorders of neutrophils? You can look at the options. Remember, in exam and GTs, whenever you are giving, the first thing that you should look at the question is the options, because that is what helps you to understand that what subject, what topic the question is from. So when I see CGD, neutropenia, LAD, myeloperoxidase, I know this is something related to immunodeficiency disorders. Please do watch the surplus topic video in pathology, microbiology in Medsynapse app. The immunodeficiency disorders have been discussed with all the tricks. Okay. So which disorder of neutrophils? It is given that nitroblue tetrazolium test is normal. So what disorder do you rule out? When the NBT, the blue test, the color wala test is chronic granulomatous disease is ruled out. Production of hypochlorous acid by neutrophils. This is myeloperoxidase. So that is also normal. So this is not myeloperoxidase deficiency. There is leukocytosis and neutrophilia, which is given in the question here, right? So remember, neutrophilia is a very important clue to identify leukocyte adhesion deficiency. Okay, this is going to be leukocyte adhesion deficiency. This is how you crack this question. So understand that in leukocyte adhesion deficiency, there are a lot of leukocytes, neutrophils in the blood, but they are not able to adhere to the endothelium and go to the site of infection, right? The migration is affected. So what do you get is no pus. There are infection sites, inflammation without pus. So basically cold abscesses are forming here. Okay, there's no pus which is there. All the WBC's neutrophils are in the blood itself. That is why there is going to be neutrophilia which is present here. What is the clinical clue here? Gum infections are common there, and there is delayed separation of the umbilical cord stump. The cord is adhered in adhesion deficiency. That is what you should remember. Delayed separation of the cord is another important clue for LAD, leukocyte adhesion deficiency. So like it is given here, the chemotactic response is diminished. So the migration is diminished. The chemotactic response is diminished. This is leukocyte adhesion deficiency. Is this clear with everyone? Leukocyte adhesion deficiency. Okay. NBT normal rules out chronic granulomatous disease. In chronic granulomatous disease, the acute respiratory burst, which is mediated by NADPH oxidase, that is what is deficient. The respiratory burst mediated by NADPH oxidase is deficient. There is recurrent catalase positive organisms infection that includes Staphylococcus, Candida, Serratia, right? Those are the common infections there. Okay. Cyclic neutropenia, as the term says, the neutrophil count will be less. This is deficiency of the neutrophil enzyme, which is elastase. Neutrophil elastase deficiency. Okay. And myeloperoxidase is a more mild disease. Recurrent candida infections are common with myeloperoxidase deficiency. Okay. Clear with everyone? Yes. So that was about the quick fast five questions for today that we had. Just give me a minute. Yes. What CD marker deficiency do you have in LAD leukocyte adhesion deficiency? Yes. What do you have in leukocyte adhesion deficiency? Correct. What deficiency do you have? So see, LAD that you have is LAD type 1, LAD type 2 and LAD type 3. Type 1 is where you have integrin defect which is there, which is CD18, which is CD18. Type 2 is T40 transporter, the fucose transporter, which is defective here. Okay. So CD18, integrin, beta integrin, CD18. Remember, adhesion is integrin, integrating, adhering. So integrin defect is going to be LAD type 1. This is where you have this cord separation, which is there. Delayed cord separation is what you see in LAD type 1. Okay, in LAD type 1. Okay, right. So that was about the today's test, guys. The fast 5. We'll keep having such tests which are open to all on the Medsynapse app and the discussions on the YouTube live sessions. And this is how you can access the annotated PDF, the test in the free content folder, the fast 5 discussion. And apart from that, there is a separate free TND course available on the Medsynapse app, which according to the timetable that I've given for students preparing for INICET, NEET PG, FMGE, the subject-wise test go live on those specific dates. You can check that out as well. Apart from that, you have freely available PYT PDFs of the previous year papers of NEET PG INICET on the Medsynapse app, and a short LMR series which is also available. For all the subscribers of the Medsynapse app, I'll see you tomorrow at 12:30 for the psychiatry test discussion. Right, we have upcoming tomorrow psychiatry test discussion. After that, on 13th, we have the FMT test discussion that is going to be there. So this was for today. I hope yes. Okay. So I hope this was useful, a quick revision of the important topics. Do watch the immunodeficiency disorders video, and there were the short book. We are working on that. Cannot tell you the exact date. And Rajat, yes, we'll put up a video for that as well. Thank you so much, everyone, for joining in, and keep studying, keep revising, keep medsynapsing, and keep winning. Thank you so much.